think if it's okay, we'll just do, I guess you get the notice that meeting's being recorded, and just do very quick introductions. And if you have anything that is really important, go ahead, feel free to share that now. So I'll start out. I'm John Nowak, co-executive director of CHIP. And I think I'll call the roll so it's easy for people. So Lori, you want to go next?
Hey, I'm Lori Fleming, Community Health Improvement Plan co-executive director.
And Susan?
I am Susan O'Brien, nurse practitioner at the school-based clinics at Chimicum and Port Townsend.
Cynthia? I think you're muted.
Sorry about that. Cynthia Osterman from the Benji Project.
Jim?
Jim Novelli from Discovery Behavioral Healthcare.
Denise?
Case call.
Denise.
Oh, Denise, sorry. Go ahead, Denise.
Excuse me, Case. Denise Banker, Jefferson County Public Health and Empowered Teens Coalition.
Julie?
Julie Canterbury, I'm MCS Counseling Executive Director, and we're in the schools and the family navigator, the police navigator, sheriff navigator, and a couple other places as well.
And Kate?
Hi, everyone. Kate Dean, Commissioner with Jefferson County.
And Case?
Case Kolf, I'm a Public Hospital District Commissioner and on the Board of Health, and unfortunately I need to leave about 10 minutes before the end. So don't take it personally, I have to go pick up my granddaughter.
That's a good mission. Jean? We're not hearing you, Jean, but it looks like you're not muted, so I'm not sure what's going on. A very nice wave. And Dr. Parker, I'm not sure if you're connected enough yet to do your introduction, but if you are, go for it. All right. I have a really quick announcement that I just wanted to share with folks, and it's just kind of a clarification that the school district wanted me to share with you, and that was at the last meeting. It was discussed about changing the contract with Kitsap Mental Health, and the schools wanted me to let you know that they haven't actually reduced the amount of counseling hours. In fact, they've increased it a little bit, and that message may have sounded like they were reducing counseling hours, but they're not. So they felt like it was important that everybody knew that. So I wanted to make sure that we kind of clarified that at the start of the meeting. And with that, Lori, I think we can pull up the slides. So agenda for today, welcome and introductions. Lori and I have decided with this group, since we're kind of trying to repair the bicycle while we're riding it, that we want to break the meeting into two parts. One is kind of the immediate actions part, where we look at, what can we do in the short term while we're riding the bicycle, and then kind of look at the mid and long range goals of updating that strategic framework that we've been working on the last few meetings. So we're going to try to break the meeting into those sections. Before we go on, are there any additions to the agenda or things that people feel like it's important that we talk about today? And I'll just give you a second to hop off mute and add anything. If not, we'll move ahead. Okay. So I think the next thing is a short presentation about mental health first aid. And Denise, I think you're the one that's going to be discussing this, so I will turn it over to you.
Okay, thank you, John. Lori and I have been talking about this a little bit in terms of the outline of a strategic framework that this group created. As the coalition coordinator for the Empowered Teens Coalition, which is in the Chimacum School District and the Port Townsend School District. And as you all may know, we've applied for funding for a coalition in the Quilcene/Brennan school districts that hopefully we will get, which will create another coalition in that school district. We want to address our zero suicide and our goal and our youth partnership or participation goal by doing a mental health first aid for teens in the school districts, right? And so that would look like all the teens have access to mental health first aid training, and they get a certification in mental health first aid training. And that program actually addresses peer-to-peer sorts of conversations and the reaching out to adult experts if in fact you are interacting with a friend who you think may or may be considering suicide. And it also would be a program that would address adults as well in terms of training them in this sort of mental health first aid so that they can recognize also the signs of suicide. There are a couple of different avenues that we can take in doing this. And Julie Canterbury might have something more to say about what's going on with MCS in terms of mental health first aid training. And also Jim Novelli might have something to say also in terms of what Discovery Behavioral Health is doing. But the way this would look for the coalitions and the premise is we want to have everybody speaking the same language around suicide. And so we thought that if we did this in all the school districts, that would be a first step in getting all the people involved in the school districts, students, staff, faculty, families, if they are willing or interested, speaking the same language around mental health first aid. And then the way that we would implement it is we first have to go after an MHPP grant funding to get a little bit more funding to support this activity. And those grant opportunities come out periodically through the Healthcare Authority, Division of Behavioral Health and Recovery, and MHPP. So I'm not worried that there won't be any funding for this. I'm actually pretty certain there will be, and that we will be able to get that funding. So another thing that I wanted to just throw in here, and this is a little bit tangential, but in terms of neurosciences and trauma-informed and resilience building certifications, Discovery Behavioral Health has sent two people, Donette and Dana, to the neurosciences certification training that I just took recently through Kitsap Strong and the OCH. And so Donetta and Dana and I have been in contact in terms of trying to get some partnership established and rolling forward on this sort of level of the building of resilience in our county. So I just wanted to throw that in, that I think the most important thing that we can do as this youth age band group is to build these partnerships around improving behavioral health throughout the county by speaking the same languages, giving opportunities to learn the same language around all of these issues, and doing a little bit of healing within our own agencies and within our county so that we can reach out together. So that's all I have. I don't really have a presentation, John, sorry.
Thanks, Denise. I think that was really helpful, and I'm just curious, does the group feel like this certainly feels like a positive direction to me, and is something that could take place in a relatively short time frame. I think Denise was talking about the fall time frame to do something like this. So we can talk about this later when we talk about the framework, but I'm feeling like this group can get behind this work, and I just want to make sure that there's consensus about that.
Yes, John, and it would definitely be this school year, whether it be fall or spring. Yes, this school year.
So John, do you just want a thumbs up, or how do you want to?
Yeah, I think kind of a thumbs up from people if they're feeling like this is a worthwhile avenue to pursue.
Yep, I certainly agree.
I see one.
We, just a little bit of add on to that, we are getting 4 of our providers trained in mental health first aid. And we're doing it through contracts that we currently have, so it won't be added on to any of the funding that Denise is working on. And one is a child mental health first aid trained, and then the other 3 are adults, so we could go within the schools and train the schools. And so that's our goal. That's a conversation we're having with schools right now.
And to add on to what Julie just said, I knew that something like that was in the works. And that's absolutely positive for this sort of idea of the mental health first aid training for the youth too. And I had thought I would have the money to fund this already, but it turns out that I've sort of overcommitted myself a little bit. And so I will have to go after a little bit more funding to boost what Julie's group is already doing with the schools. So, yeah.
John,
Great.
if I could ask.
Go ahead.
So I think this sounds really great. I think it, really empowering kids to play a role in prevention is really important. So I like that this is targeted and kind of empowering them to take an active role. I'm curious if the training for the youth is that an established curriculum that is made specifically for this age band? Okay, great. I think that's really important that
There's 2 avenues. One is adults and the other one is teens. And so we're doing the 2 different avenues.
Okay, Julie, I couldn't tell if you were saying that your professionals were getting trained to do mental health first aid for youth, or if the training is specifically designed to teach youth how to intervene in this way. That's great.
Yeah, it's the curriculum of mental health first aid through National Behavioral Health. I can't remember the name of it, but it's a specific form of training.
Yes, and Julie and I are talking about the exact same.
And I think given the data that Cynthia showed us at the last meeting, where kids are more likely to go talk to other kids, it's really important that we include kids in that formula. So I'm excited to hear that this is an opportunity to do that. So great. Thanks very much. I think that's a really good concrete step that we're taking, and feels good to me. Lori,
John, John, just to add to, for Kate's information, I took this training, not last year, but the year before in Clallam County, and there were so many kids who were in the training. It was beautiful. It was absolutely addressed to their interactions with each other. It was great.
Great. Lori, I think you were going to speak to this slide that's on the screen now about how we're hoping to integrate the CHIP work with work that's going on in the schools and other agencies in our community. So I'll turn it over to you.
Jean, did you have something you wanted to say before I jump in?
I just had a question for Denise and Julie about, is this something that would be part of kind of all students' curriculum, or is it like something students can volunteer to get certified in? Or maybe we don't know yet. I was just curious.
We don't know yet. It's still in the conversations.
That is a nice lead-in, though, to the thing that we're thinking about here, shown on this slide. One of the things that is clear is you need some key momentum with the school district in order to get these programs going. And that can be really hard to do with 3 different school districts and the variety of players that are involved. And one of the things that we have learned is out there is this Jefferson County Education Partnership Group. So that's a group that has 2 representatives from each of the school district's boards and they meet, I think, once a quarter. And I wondered if we might consider a strategic tactic of having somebody who has some weight. And I was thinking on this one, it could be, a Kate Dean and a Case Call kind of a combination, who goes to that meeting and presents to that board saying, as a community, we have gathered this group under the CHIP umbrella, of which, the Empowered Teen Coalition is a key member. And we, as your community, want to work with you to address what the surveys are showing us are challenges in our community around adolescent suicide. And perhaps in taking it at that level, so that we're going from the grassroots up, and we've also asked them at the highest levels, and maybe we want to ask something very specific, a key individual in each school district or something that we work with, so that we're being very intentional that this is our purpose, this is what we're here to do, and we need their interaction with it. And then it also provides a shorter or maybe more concise way for them to interact with folks about the various programs that people want to get into the school. Is if this is where you come to sort of vet it and get it taken care of, and this is where we can expect then to interact with them about getting it engaged, and what are the metrics, and how are we, how is it being rolled out? So it's an idea that I put before you. It's not a fully fleshed out idea, but it seems like a worthwhile thought that infrastructurally we need to do something to shore up our relationship with the school district.
Thoughts or comments about that?
Hey,
Yeah,
Lori. I think that it sounds like a good idea. I think from other committees I've been on, it really does help to have someone in decision-making capacity to sit on those committees to help move change forward. And so asking them for a representative to be on this committee would be great. I think in the past, they've had superintendents be on our CHIP committee for immunization, and that made their policies change more quickly, their communications change more quickly. It was really helpful, but I don't, again, I don't know their capacity to do that.
And to Molly's point, sorry, Jean, go ahead. With the superintendent on the CHIP immunization committee, that worked really well, because I worked with the superintendent down in Chimacum at the time, and he spoke very highly of how they got things going and how they made things work based on his participation in that group. And Lori used the word shore up in relationship to the school districts and our relationships. And I would say, rather than shore up, it would be to expand and deepen our relationships with the school districts, because we actually, with the student population, we can't really get anything done unless we have the school districts on board. And we can't be sitting here making decisions and plans without having the school district on board, because we're making decisions that affect them. And so I learned that a little bit the hard way by trying to press the school district in a variety of different ways to adopt this PACS Good Behavior game, which I believe in 100%. But I kept going through them and then wouldn't get any response. And then I'd go around them, and then I'd go to agencies that were working with them, et cetera, and so on. And it got really complicated until finally they said, stop, we don't want to talk about PACS Good Behavior games. So, that illustrates that if they're not on board and they're not completely informed and in partnership with what we're planning for them, that it makes it a whole lot more difficult to do anything with the student population in the county.
Jean?
I'm just going to echo that and say something similar from my experience in working with the schools, is that it is all about your relationship. It's all about relationship. And we definitely don't want to be making decisions for them without getting their input, because really they are the ones who are in touch with their student populations. So they know more than we do on the ground level about what is needed in their communities and in their schools. And what's needed in Brennan is really different than what's needed in Chimacum, for instance. So not to say, that we need to, what I am finding in working with the schools is that how we are showing up as Jumping Mouse is looking different in different school communities, basically. So I think it's just essential to have them part of the planning, even of what programs we're choosing and how we're implementing and all of those things.
And that's exactly true of the work that the Empowered Teens Coalition is doing in Chimacum and in the Quilcene Brennan School District. So I am on both of their wellness committees in all those districts. And so that provides me a voice, a place to include and also get ideas from and take direction from those two groups, and also to establish their familiarity with me, my programming, and what it is I have to offer. I think Susan could speak to that also in terms of the school-based health clinics.
I also wanted to say, and then Susan, I think it's also, we want to be respectful of their time and bandwidth. I think that that's a big selling point of this. This would be one point that they would have to go to instead of people coming at them from all sorts of different directions. Susan?
So I'm not exactly sure what the question is, but I totally agree that partnership with schools and connection makes all the difference in the world. And I don't know if there was a specific question, but yeah, I can definitely say that's true.
So I think Lori and I can take that information and weave both of these items, both the mental health CPR and the relationship with the schools, and come up with specific language around that to put into the framework. This meeting of the superintendents occurs quarterly, and the meeting is actually next week. So it's probably too soon for us to be able to do that. But what we can do is strategize around how to do that for the next meeting. And I know Lori and I have some contacts, and I think we'll be able to get on the agenda to have that conversation. And we might be talking with a member or two of this group to come talk with us when we do that.
Should we ask if Kate and Case are on board with the idea that we use somebody with a heavyweight to present at that board?
I think you just did.
I'm happy to do so. I'm aware that many of you have much more kind of clinical and day-to-day experience. So I feel a little underqualified. But happy to do it if kind of political angle is helpful.
And I'm also willing to help, however, but echo what Kate said.
Great. Okay.
Julie, did you have a question?
I'm just saying, me too. I'm available.
Okay.
I
All
had
right.
one other question as you guys speak to them that might be worth asking, and that's are they already working on this in other forums with other groups? Is this asking them to participate in this? Is that duplicating any work that is already going on that we should know about? Because I certainly wouldn't want to do that either. So.
Yeah, I think that's a really good question. Go ahead, Denise.
Seconding that with Molly, I know that Port Townsend School District, as reported by Carrie at our last meeting, has something that they're kind of trying to get into the works for next school year in terms of mental health first aid for youth. And so in Quilcene, I know they want something to happen. And I also know that Ciela Meyer at the ESD 114 at that level has been doing a lot of work in terms of mental health first aid too. So they might have something that they're working on with her. She'd be a good member for this group, I think.
You know, she's on the invite. We'll see if we can get her here.
All right. We are gonna just do have Jim Novelli do a little discussion about what Discovery Behavioral Health Care does in terms of adolescent and youth counseling, just to make sure everybody kind of understands the mental health landscape in our community. So Jim, I'm gonna turn it over to you.
Thank you, John, for the time. So first slide up there is Lori's slide master, I believe, master of all slides. Is just really an overview of all the different services we do with community behavioral health, what we do at our facility. And, you know, it's really the soup to nuts of everything. And this is one of the areas that I've been kind of concerned since I've come here is, you know, we're a Medicaid provider, a licensed behavioral health care agency through the state of Washington, and our services are mostly Medicaid. I've worked in two different areas in Montana and Eastern Washington with school-based programs. In Montana, it's called Comprehensive School and Behavior and Community Treatment. Those are all Medicaid funded programs again. So I started doing some research and I realized school-based health services in Washington are funded by HCA. And mental health is funded through school-based health services for Medicaid. And actually the schools can bill Medicaid. I don't know if that's happening, but schools can have an access to billing Medicaid to provide mental health services. And these are kids that either have IAPs or individual family plans. I know it's kind of restricted, but again, I was talking to Celia the other day and actually have a meeting with her and Kristen next week. And I know Sue, we're going to get together a little bit, is to really kind of see where's the Medicaid eligible kids, where are they falling through and where are they getting services? Because I'm not seeing the referrals here, and that really worries me. That kids that have Medicaid, you know, obviously they can't afford to go see a private insurer. And by rule, 1/10 of 1% money can't really cover Medicaid kids because it's using double dipping basically. So I get concerned about how Medicaid kids are getting those services. So I've been talking and trying to figure out, and that's what Kristen Schutte wanted to figure out, is how DBH can help with some of that Medicaid level services. And I don't know if the schools are going to be willing to even want to bill. And when I was over in the eastern side of the state, we provided schools and school-based services, and the schools billed the Medicaid and made it easier for us. So anyhow, just a thought there. So just looking at our different services, I don't want to read to you. Obviously, you're able to read, but one of the programs we do have is our WISE program, which is a Medicaid-based program, and it's a very intensive program. Sorry, the print's small on here, but and this only allows up to 13 kids at a time in that program. But this is a complete wraparound program that is staffed by 2 peer counselors, one being a youth and one being an adult peer for family counselor, as a care coordinator, a therapist assigned, and they really work with these kids one-on-one. They go into the schools, they have child family team meetings, and this is a very intensive, and these are for kids that really have some of the most serious and troubling, obviously mental health issues. And, this is really an interesting program because I find it hard to really do true therapy in the schools. When you have a kid that is very ill, therapy in the school is not something that works very easily, because you don't want to open up a kid's baggage and then say, oh, it's time for you to go back to the classroom. So, most school-based programs really focus on counseling. Whereas, my question becomes is how do we get to doing the therapy for these kids that really need the help? And WISE is one of those programs that really works with kids in and outside of school and even at the home. And so we have one team right now, that stays full, pretty much 13. I wish we could get more than that, but we only allowed up to 13 at a time. I'm hoping that maybe down in the future we can grow a second team, depending on demand. But here's just some numbers I wanted to share with you. This is just from the beginning of the year. And I think these are interesting because this is during the, middle of pandemic, I guess, January, February, March of this year. As a whole, we've served 720 clients in Jefferson County for those months. And from just looking at the age ranges of that, about 107 of those were youth. And those are kids that were not seen in the school. These are kids that come to our door, that are brought to our door. So we do have a very active adolescent program. We have several therapists that work with kids. And I'm glad to say that we just got a hire yesterday of another therapist that's going to work with children. But so a total number of services, that's what really how intensive these services are. Of those 700 people, they receive 5,000 plus services over those 3 months. It gives you a level of intensity that occurs here. In crisis, which is another part that is a crisis always available to our schools. Anytime a kid is really struggling in the classroom or making statements that are suicidal or, threatening anybody in the school, our crisis team is mobile and is able to appear at those schools and help out. And in those 3 months, we served 175 clients, of which 40 of those were kids that we saw in crisis. So, I mean, these are kids that come to our doors, and these are not based on referrals. These are just what happens. And then our WISE actually has served up 14 kids that have been enrolled in that program for the last several months. And it fluctuates. One leaves, one comes in, but it stays at that level. But this shows you the intensity of services when you look at the number of services each of those areas receive. It's a lot of time and a lot of individual services that are given out. So what I'm trying to figure out is how do we prevent fragmentation? All right, we have lots of different people doing different things across the board, and how do you get from point A to point B? We serve the Medicaid population. We have 4 nurse practitioners on staff now. We're able to help with medication evaluations. So how do I get people into our program that need that level of care? Because we do provide that whole range of services. There are certain things that we do that other people can't do. Case management, working with families, that is very different than what other programs have the ability to do. So what I'm trying to figure out is how to get referrals over here, because I'm not seeing those referrals. I work with my team. I hear about kids in the school that are struggling, but I'm not a mind meld. I can't guess who needs help. People need to call. Now, granted, things are busy right now. I will tell you, in the state of Washington, I'm on the board of directors for the Washington Council for Behavioral Health. We have several agencies in the state, more than several, actually. We have several large agencies, Comprehensive up in Everett, Frontier in Spokane, that have literally closed down new admissions to their outpatient programs or throttling down admissions because they're just overwhelmed by the number of need right now and the lack of resources that they have staff-wise. So we're seeing this across the board in the state right now. So it's very difficult to access services. Knock on wood, right now, we have not had to slow anything down or creating waiting list right now as of this point. I say that today, it could change if we keep having these surges. I talked to a colleague over my old agency in Okanagan that had 107 requests for services in the last 2 weeks. And there's just no way they can keep up with that number with 5 therapists. They're in a very rural community too. So this is, really where it gets scary. And but right now, if we are made aware of help, I prioritize, because Medicaid is our primary insurance, and we have to take kids with Medicaid. We do not put them on waiting lists. We try to get them in as quickly as possible. That's our goal. I say that, and we've been good at doing that, but again, when the numbers outstrip the number of therapists we have, that's where we're a problem. But right now, we're sitting pretty good. We're getting close to our caseload max because we really want to make sure our caseloads are appropriate so our therapists can provide their services in an ethical manner. Because obviously, if you give too many, if caseloads are too large, they can't serve people quick enough. So we'll make sure they see people in a short amount of time. So that's my goal, is to really, and that's why I'm going to meet with next week with people next Friday, I believe. We're meeting a group, is how to really help access to Medicaid level students. And I can see more than just Medicaid, but I'm just really concerned that right now they're not possibly getting all the access they need. And I just want to make sure that we're attending to those children that are in the schools. So any questions, I'm glad to ask. Go ahead. Molly or whatever, see hands, or John, that's your job.
I'll jump in. I'm not shy. Thanks for letting us know about everything that's going on there. I think one of the as a referrer and somebody who sees adolescents, one of the challenges I've had recently is just knowing what's available. In the past few years, there's been an ebb and flow in prescribers who will see kids there, and also therapists who will see kids, and also understanding what types of therapy are happening. I think a lot of the kids need very specific therapy, and I know you guys are experts at figuring out what type of therapy they need, but it's difficult for us to send a kid who's heading towards a crisis, who needs very specific therapy, to a place where it's a little bit of a black box. So I would love to just know more about your services, and I think that would help with your referrals if we at Jefferson knew more about what you're able to offer right now.
So, I mean, I don't know if you're aware, I meet with Jefferson Healthcare on a regular basis. We have a monthly meeting with the primary care people to discuss referrals and treatment. And we also meet over emergency department things. So that might be a good place for you to, if you can ever get to join one of those meetings. It's usually on a Tuesday. Many times it unfortunately got canceled because of COVID. But lately we've been meeting again. And that's where I discuss a lot of what kind of services and what gaps we need to fill. And,
I can touch base. Who do you meet with?
Dr. Butterfield or Dr. Madden or Jen Morton.
Perfect. Okay.
We'll get those meetings. Okay.
Yep. Thanks.
That'd be great. I'd love to have you on there. So.
Denise, did you have a question?
It's more of a comment. I know that the student assistance professionals at the schools, Holly is at the Blue Heron School right now, and Ciela Meyer used to be the one that was at Chimacum. There'll be another person in her position next year, but I know that they have done referrals to Discovery Behavioral Health for crisis management for sure, and also then for regular Medicaid therapy. Yeah, so that's a good place to get referrals.
I have a question. So for your child therapist, what is their specialty and how many do you have so that we have an awareness, we can look them up on?
Well, we've got, several people that see children. I don't know exactly what their specialties off the top of my head, but we have a WISE therapist that works just with children. So she sees children as our WISE therapist. And then we just hired yesterday, we have a new person that's a licensed marriage and family therapist that is going to probably see some children. As for our prescribers, Ren, one of them does see children, and Kel does see some children. So we have two that see children there. So we have and we have a new nurse practitioner that should be starting hopefully in July or June. And I'm not sure where his role is. He may take some teens and stuff like that, but he's a new graduate from the Spokane area. So we're going to play that all out. But we do have several people that feel comfortable seeing kids. And that's where we're trying to, move into. And obviously our TCRs are always available to work with kids in crisis, especially when it comes to suicidality and getting them the help they need. And I think I know that's been a big topic for you guys, is really this whole suicidality and, really that awareness. So, and making sure we can, take care of that problem and be there.
Thanks for taking that. I think it was really helpful for everyone to kind of get some idea of the services that you're providing. And I think it kind of represents an upgrade or a change in your level of service in the last couple of years. And it's nice to get kind of an update so that people are aware of what you're doing now. So, Dr. Parker, maybe you could, kind of further after you go to that meeting, maybe you could get the word out to more primary care providers about the services that are going on at Discovery Behavioral Health Care.
I probably will just coordinate with those guys and just learn more from them and what they know, since Tuesdays are my clinic day. But and then I'll defer to them to get it out to the rest of the hospital. But
okay.
delegating.
We get a lot of referrals from Jefferson Healthcare. So that's what we work on, is making sure those referrals. And actually our nurse practitioners do a lot of consultation back and forth when we send we share patients. Sometimes we see patients for a while, then they no longer need the therapy, but they still need medication, management. We'll send them back to primary care, but we can help consult with that if things, go sideways or something. So.
One quick question, Jim.
Sure.
In the statistics that you showed of number of kids coming in crisis, I think you said something about that those were not referrals, or does
Well, in a sense of referral, I mean, the referrals to crisis, that's for sure. So, I mean, in a sense, I don't know if they came from the schools particularly. They weren't referred out of the schools, but those are the number of total kids age range that we saw that showed up in the emergency department usually. So that's why it's not a referral. They usually show up in the emergency department.
Okay, thank you.
Yeah.
Dean, did you have a question?
I just wanted to say that, well, thank you for all the work that you're doing. And I work at Jumping Mouse Children's Center, and we do refer families over to you. And definitely when we get calls for families that are more in crisis, because that's not really, we're not a crisis service. I wanted to clarify, I thought you said that you do case management with families, or did you say that you don't?
No, we have case management services here.
Okay.
And if they meet the need, we can, fit them in.
Yeah.
And I forgot to mention, we do have a gentleman that just joined us from California. He's part-time for us until he wants to work, but he was a licensed marriage and family therapist and actually worked with juveniles in Marin County in the probation department. And so we're really glad to have him on board, because I think he's going to be a really good addition to helping working with some maybe more difficult kids or juveniles that might be struggling. So, yeah.
Thank you.
Okay, for the sake of time, I'm gonna move us on. We're a little behind schedule. I want to impart in you a little bit of a sense of urgency about trying to complete the strategic framework. And the reason is that, Lori and I have a goal of, I'm retiring in August and have a goal of trying to have something to put together for the entire CHIP plan at that point. So we'd like to move this on as much as possible between now and August. And maybe next meeting we'll put the framework at the top of the meeting, though I think this discussion is always incredibly helpful. So our goal for today was to try to get at the goal and objective and strategy level, get this framework as knocked out as possible. And I think what we're hoping to do today is kind of look with you at what's currently in the plan at those three levels, and get kind of a thumbs up or a thumbs down in terms of the content, and then kind of try to get 90% of the wording down, and then Lori and I will take that and do a little bit more wordsmithing. And at the next meeting, we'd kind of like to get final approval for things at the goal, objective, and strategy level. So I think, Lori, is there, oh yes, thank you for waving the mouse across there. We also want to talk about who's owning those things at that level, who has kind of the primary responsibility for that. So with that, we're going to take a look at the strategic framework the way that it is now. I think just also in terms of, being the most efficient that we could be, I would encourage any of you to look at this between our meetings, and people have sent us feedback on the strategic frameworks, and I would say, please try to keep doing that. We pretty much always add that so it can at least have some conversation. And since we only have about 15 minutes left in the meeting and probably aren't going to get very far on this, I think the more we can do between meetings, that would be helpful. So right now at the goal level, we just have a single goal, which is implement a plan to reduce Jefferson County adolescent suicide to 0% by, and the year-end date is undetermined. And I guess I have two questions to kind of shore that up a little bit. One is, what's the date that we want to set there? And the second is, right now, that is our only goal. And there's a lot of strategies underneath that and objectives that kind of get at some of the detail of that, but are you guys comfortable with that being the only goal in the plan? So with that, I'll turn it over for discussion.
You know, I have been in receipt of an email from Rachel Hall, I think is her name. She's somebody who is doing the Washington State's Childhood Action Programs for Washington State. And she has requested some interaction with us and with CHIP and with public health about possibly using CHIP as a place where we advance those initiatives, or where we're the sort of focal point for advancing whatever the statewide down to the region wide, then down to our county efforts would take place. And I have not had a chance to talk with the folks at public health, but that could very well become something that is the next, that is a second goal, and that is to support the state's program, or just to support the region's programs that have already been set by this greater agenda here in Jefferson County. And then what the specifics of that would be fleshed out. But it's a conversation that's very much in progress, so I didn't want to put it into the framework yet.
Keeping that in mind, I'm comfortable with this one goal. It's a pretty big one and important, and I don't feel like it needs to be diluted, but I'm still open to hearing other people's ideas.
I'll just second what Molly said. I feel like this goal is big enough and important enough that there's a lot of other smaller goals that it encapsulates, you know, which is just general overall mental health in our community for teens. So.
Any thoughts about I mean, personally, I think the year should be soon. But thoughts from the rest of the group about that?
I'm kind of curious about that time frame. Is it within the year of 0, or is it within a quarter? Or, I mean, I think it's that's a big one of the 0%. And so if there is a 1%, what does that? I'm just curious of what that means. Or is there a time frame of it? Is it a full year? Is it a 6-month period? I'm just curious of what that thought was.
I mean, I can speak to how CHIP has done those goals in the past. I mean, what this would say is that we would have no teen suicides from whatever date if we set 2022, but after 2022, we have no adolescent suicides every quarter, every year. And that's how we've done those in the past. And I think, to me, that's the right goal, is to not have any. And I know you can't always achieve that goal, but I think that is the goal we want to set.
I think other communities have done it both ways, both the way that you mentioned, Julie, with by quarter or by year, and then you track it based on either of those. So I think kind of looking at also how CHIP works is usually, at least in my experience with the immunizations, the immunization goals were all yearly. So how did things go for the past year? And then, you try to tweak it and improve it for the next year. So by year would probably be useful, but we'd obviously watch it by quarter. And then as far as like by when would we want to have accomplished this? I agree with John, yesterday, but when is the next community health assessment? It's every 3 years, right? So we could push it out until the next community health assessment. We want to spend the next 2 years doing this, or do we want to just say by the end of 2022 we want to do this? I'm open.
I'll just throw out that I would favor that we set a date before the next community health assessment, because that is a little bit funding dependent, and you know, if for some reason we didn't have the funding to do the assessment, I'd hate to have that date just keep getting, you know, pushed out as a result of that. So yeah, Kate, go.
I know you said you didn't want a wordsmith, and I know how annoying that is. But the reduced to 0% seems clunky, and it also doesn't address attempted suicide and ideation, doesn't capture a lot of the other addressing risk factors leading up to, and I get that it's a goal, and so it should be, but you know, and if I think, I feel like it misses, I mean, I like certainly agree with like eradicating if possible, or I just think there's a different word choice, and then also if we could somehow address the attempts,
Yeah.
and get at some of the underlying, you know, like the actual, by the time it gets to suicide, that's, you know, that's
Too late in the process sometimes. Yeah.
Yeah.
Kate, do you have any suggested wording?
I'd have to think about it, and I think
Okay,
probably a
that's
lot of
fine.
people have better word choice.
And I didn't mean to say that we didn't want to wordsmith at all, because we do, obviously. We just don't want to get down into move the from here to that, you know, from here to there or whatever. So
Could we pull the goal from the zerosuicide.org and just use the same wording for their data? I'm trying to look on their website to find it, and it's not popping up to me right now, but it'd be a nice way to compare our measures with other folks.
It's a good idea.
yes. Molly, if you send me the link, I'll dig down and find it.
Yeah,
Denise,
you
did
bet.
you have a
Thanks.
comment?
Yeah, in terms of the community health assessment, and then also what Kate said about, you know, maybe that zero suicide doesn't take into consideration ideation and attempts, that kind of thing. The Healthy Youth Survey information comes out every 2 years. There'll be new Healthy Youth Survey information that'll come out in the March or May of 2022. Because we're giving the Healthy Youth Survey in 2021 fall this year because we couldn't do it last year. And so that will give us some thoughts and some information about where kids are in terms of their thinking, in terms of depression, suicide, suicide ideation, those kinds of things, which is where we got the information to set up this group anyway, based on our last assessment and then the creation of the groups based on that information from the Healthy Youth Survey. So that would help to inform if we're moving the dial at all, I guess is what my point is. So maybe if we did say that we wanted to check within like by March of, or by Healthy Youth Survey data results in spring of 2022, we wanted to check and see where we are. But for our overall goal, then it is more based on that 3-year community health assessment. So what we're doing is building in these checking points to see how we're coming along on our goal. And then we're going to measure our goal fully at the end of this, you know, period or something like that.
Yeah, I totally agree. But I also think in this community, because we're so small, I think we're pretty aware of when those kind of critical events take place in our community. So I think we can, to some extent, know whether we've had an adolescent suicide in our community. Within this group, I think there are enough resources to figure that out. But it is, I agree. We definitely need to keep an eye on the community, on the Healthy Youth Survey, because there's information in there that Molly was referring to in terms of suicide attempts and ideation and those kind of things that we're not necessarily going to have data on when we between times we have the Healthy Youth Survey.
We probably will need a data source that's official, not just like I heard this happened last week.
Yeah,
So
yeah, I agree. But I also think we will be somewhat aware when those critical events take place. We are coming to the end of our time, unfortunately. So I will work on finding the wording, Molly, from the website that you're going to send me and seeing if we can plug that in at the goal level. I think the consensus that I heard is that that one goal is a good goal. We may need to wordsmith it a little bit. And Kate and others, if you have thoughts about how to word that, just send it to Lori or me, and we'll try to get a consensus from all the input that we get and put that in there. I am thinking about looking at this at the objective level at kind of two areas. So I'm just going to put that out there, and you can ruminate it on between now and the next meeting. One is about improving resources for adolescent behavioral health, which is already in there. And then for me, there's a bunch of things that are at the strategy level that I would actually move up to the objective level, and that's kind of improve the care coordination that takes place in our community, so that the pathways for our community members to get mental health help is not so complicated, and that there's better communication between agencies that provide mental health in our community. So in my mind, those are the two that kind of rise up to the objective level, and then we can start talking about the strategies underneath those. But we have 1 minute left, and I'd love any comments on whether you think that's in the right vein. Jean, did you?
Yeah, I just wanted to add that, the family navigator role that was created, that is now housed at the YMCA, that was a big intention for that role, to help with that community collaboration and helping streamline. And I know it's family focused, but so I think we should not duplicate what is being done there.
Yeah.
So that's all. But I think those are both really important goals.
Yeah, I totally agree, Jean. I also think something that we do in CHIP is just make sure that a lot of activities that are going on in other places are just kind of melded into the plan. So I think we would be totally supportive of that idea. And also, I think the funding for that is somewhat temporary. So I think we might need to look at what's the long-term strategy to be able to continue that after the CARES funding goes away. So we are at time. So I just would encourage all of you, if you have an opportunity to look at the framework, give us any feedback that you have. And I'd really like to see us move that along as far as we can in the next, I think we have 3 or 4 meetings before I retire. So I'm really hoping we can get something kind of framed up. And I'd like to be looking at the activity level with, by the next meeting or the meeting after that. All right, any parting words from folks? All right, thank you all so much for participating. And I think this is really important work, and I'm really proud of the work you guys are doing. Thank you.
Thanks, bye.
thanks, everybody.
Thank you.